is under attack because it's expensive. And it's expensive because it insures our elderly population at the most expensive time in our lives to receive medical care, right? If we're lucky enough to grow old, we use more health care as we do that. So President Johnson knew, actually, even back then, that the only way to get health care costs under control was to have everyone in one big health plan. Old, young, sick, well, that mixture balances out the costs over time. So let me ask this question. How many of you have Medicare and yet continue to pay thousands of dollars out of pocket each year? Pretty much everybody, right? Well, we happen to think at the Minnesota Nurses Association that it's just plain wrong to have people who have worked their entire lives to be afraid to go to the doctor because they can't afford co-payments, co-insurance, or they are cutting their pills and rationing their expensive medications. So let's just take a look at how much we are really asking seniors to pay. So if you look at that slide right there, you will see that we'll start with Medicare. So you know that Medicare costs you money, right, out of your Social Security. So Medicare premiums for Part A and B are a minimum of $135.50 per month and possibly more because we do means test Medicare, right, based on your income level. Then you've got a Medicare supplement, right, because Medicare only pays 80%. So now you have to buy a supplemental plan to cover that other 20%. That can be, you know, anywhere, I guess the national average on that is like $300 a month. Some are a little cheaper. I know when my mom had UCare here, it was closer to $200 a month that she paid. And then we have Part D, right, on the pharmaceuticals, so about $35 a month. And I do want to say a word about pharmaceuticals, just as long as I'm here and I have an audience and I'm on the Attorney General's task force. So don't for 1 minute think that pharma is about patients. It is at 100% about their wealth and not our health. And you don't have to take my word for it. I'm going to go ahead and read to you directly a quote from a CEO of pharma. Now I need my glasses. His name is J. Michael Pearson, the CEO of Valiant Pharmaceuticals. And he did an interview with MSNBC where he said his company's responsibility is to its shareholders, not the customers who rely on their drugs to live. He said, my primary responsibility is to Valiant shareholders. We can do anything we want to do. We will continue to make acquisitions and we will continue to move forward. If products are sort of mispriced and there's an opportunity, we will act appropriately in terms of doing what I assume our shareholders would like for us to do. There's another Eli Lilly exec who actually said when they were debating a price for a drug and someone pushed back and said that's too much money, you can't justify that amount of money for that particular drug, and he literally said, you know what, if grandma's on the table, they'll pay anything. That's a direct quote. That's why we can't have a marketplace for health. Because we don't buy health like we buy other things, right? You know, because it is kind of true. If grandma's on the table, we probably will pay anything. It's just where is that money coming from? And is that actually the price that it actually costs? That's the big kicker, right? So when you start to add this up, you see that you've got a monthly total of a little over $470 a month, which doesn't include those possible co-pays, deductibles, and co-insurance. So now let's just take a minute to think about what could be the deductibles and co-pays paying for. The next slide, if you want to go to the next slide. Thanks. Podiatric care, chiropractic care, acupuncture, mental health services, because we all know that mental health isn't about health care, right? What does that have to do with it? I mean, how do we separate these things out? Inpatient, outpatient hospital services, diagnostic services in labs and imaging, durable medical equipment. Again, you know, you need a wheelchair. That doesn't have anything to do with your health, apparently. Prescription drugs. And when you add this up, it really does, make it clear that it sure isn't cheap. So you can go to slide 4. The Kaiser Family Foundation projects the average senior on Medicare spends approximately $6,000 per year out of pocket after Medicare pays. Think about it. How much do you pay for the things that aren't covered by Medicare? You go to slide 5 now. Things like long-term care insurance, if you can even afford that, right? Dental care, vision care. Again, how is dental care and vision care not part of our health, right? Emergency services, both care and transportation. We have people now taking Ubers to the emergency room because they're terrified of an ambulance ride because of the bill they're going to get afterwards. Home health care. There is a young man, 35 years old, named Audie Barkin, who is dying of ALS. And you should absolutely, look online and Google about Audie. He's fighting for Medicare for all. He's fighting for you. He's fighting for me as he's dying. And he has to try to raise on GoFundMe over $9,000 a month. He's an attorney. He has good insurance. But he has to raise that money because insurance will not cover 24-hour care that he needs in his home. They will, however, pay for it if he will go to an institution. He does not want to die in an institutional setting. He wants to be home with his 3-year-old son and his wife who is pregnant with their daughter and due to deliver in November. It's absolutely horrendous what we do to human beings in this system. Dialysis, adult daycare, rehab and rehabilitative services, long-term care itself, acupuncture, podiatric care again, transportation, hospice care, care in a skilled nursing facility, chiropractic, adult daycare. All of those things start to add up big time as we get older. And assisted living costs, the average across the nation for a senior is about $4,100 per month. And if you need long-term care, well, let me tell you a story about someone who did so. You can get a glimpse of just how inhumane and financially devastating that can be. In February of 2019, there was a Forbes article that was entitled, "Why Seniors Should Be the Strongest Supporters of Medicare for All" by Nancy Altman. You heard Buddy refer to her earlier, president of Social Security Works. And she wrote about Leon Lederman, a brilliant physicist who had recently passed away at the age of 96. Lederman had won a Nobel Prize in 1988, but he was unable to leave that prize medal to his children and grandchildren for them to cherish. Because in 2015, Lederman and his wife actually sold the medal for $765,000. So you might wonder, why would they depart with such a rare and distinguished honors? Well, as it turns out, in his 90s, Lederman required long-term care. He and his family needed the money to pay for the cost of his care. You can go to slide 6. So the cost of a semi-private room, food and house cleaning in a nursing home averages $225 a day, or about $82,000 each and every year. And the current Medicare program does not cover long-term care, neither care at home nor in nursing homes. Most families cannot pay that bill by selling a Nobel Prize medal or anything else worth over $500,000. Instead, seniors like my mother, who passed away in 2017, just 1 month shy of her 94th birthday, are generally forced to impoverish themselves so they can qualify for Medicaid, and that's medical assistance in Minnesota. Once poor enough to qualify, they are restricted to facilities that accept Medicaid patients and can be subjected to other difficult and painful limitations, as Medicare rules vary significantly state to state. Even if their families want to care for them at home, Medicaid may make that choice impossible. Depending on the state rules, Medicaid may pay for institutional care, but not the cost of what families need to keep their loved ones at home, like Audie. I'm going to pass, or I think we passed out, or we're going to pass out a spreadsheet to give you an idea. I'm not asking you to do this right now or anything, and it's kind of colorful, but it just gives you an idea of thinking about what kind of costs are you putting out of pocket right now as a senior citizen, on a fixed income, on Medicare. What are you paying up and above that? And yeah, they're over here. And, oh, thanks, Sue. Are you going to Help grab them, thank you. So Sue will get those out to the table. So it's just something to give you some food for thought when you hear people talk about Medicare for All and you think, wait a minute, is that really going to be the way to go? How is that going to impact me as a senior citizen? I think it will give you a real visual on a reminder of how costly it is to grow old in America. You know, the fact of the matter is, brothers and sisters, our healthcare system is completely unraveling. We have a healthcare market, not a healthcare system. Healthcare costs are bankrupting seniors, working families, and people who have the unfortunate experience of getting sick, something that happens to all of us. Even Medicare, America's most popular and best administered program, is suffering. The universality of the Medicare program that was originally intended is now being undermined by the expanding role of private, for-profit insurance companies that are required to cover the costs that traditional Medicare does not cover. Medicare covers less and less each year, and we pay more and more for supplemental insurance, premiums, co-pays, and uncovered procedures and medications. That is not the America that you all worked to build. What we need is an improved and expanded Medicare for all, and that's exactly what H.R. 1384, Washington State Congresswoman Pramila Jayapal's Medicare for All Act of 2019 is. A bill that will resolve the health care crisis for all Americans, including the elderly. So how does it work? Every American is covered by one plan with comprehensive benefits. You can go to the next slide. So for Medicare beneficiaries, there will be no need for supplemental insurance to wrap around Medicare in order to pay that 20% that Medicare doesn't cover. And that includes outpatient care, prescription drugs, and so on. Medicare for All would cover all these services with no more premiums, deductibles, or co-payments. Premiums to insurance. You will have your choice of providers. This is critically important because we hear this a lot these days, right? In the news. Well, they're going to take away my private health insurance and therefore I won't have any choice. Really? Is your choice about what insurance company to hire to get health care from? They don't provide health care. Nurses provide health care. Doctors provide health care. Technicians provide health care, right? Not insurance companies. This is nuts to have that as an argument. I don't know anybody who's in love with their insurance company. I do know people who love their doctors and nurses, however. You will have your choice of providers. It allows for competition by allowing you to choose the provider that you want to see. You won't have to pay for supplemental insurance anymore. Benefits that are not currently covered by Medicare will be added, including, ta-da, vision, dental, hearing, podiatry, home health care, and other long-term supports and services, mental health care, durable medical equipment, and more. Seniors on Medicare will save considerable money. You will still pay your Part A premium out of your benefit check, but Part B premiums will be eliminated, and Part D drug costs will be eliminated or at least markedly cut, because we'll now be able to negotiate with pharmaceutical companies for our drug prices like every other industrialized nation in the world. That got slipped in the middle of the night by the drug, by pharma lobbyists, right? When they did Part D in 2003, you know that? I mean, literally, in the middle of the night, they slipped into there to make it illegal for our government to negotiate drug prices for Medicare, our largest health, social safety net health program in the country. The VA, any vets in here? The VA gets to negotiate drug prices. Why wouldn't we do that for Medicare as well? There will be no more need for Medigap policies, and Medicare Advantage will be eliminated because the new system will cover what Advantage plans do now. So since I'm in the House of Labor, addressing retired trade unionists, I do want to say a few words about the healthcare crisis impact on our brothers and sisters that are still in the workforce. Health doesn't operate, as I said earlier, under the basic economic theory of supply and demand, because health isn't a consumable good, it's a public good. We don't decide to have a heart attack one day because Alina has a discount on bypass surgery, right? It just isn't the way health works. As Medicare for All is gaining traction, including the support of numerous labor unions across the country, Even our own Minnesota State AFL-CIO has passed a resolution in support. There is a new talking point going around from those who wish to keep the status quo simply for their own selfish economic greed. That talking point says that everyone loves having their health care tied to their employment. You know, our employer-based insurance. Well, after 30 years in the labor movement, I can assure you, I'm not finding that to be the case. Did you know that the U.S. Department of Labor estimates that about 1 claim in 7 made under the employer health plans is initially denied? That's 200 million claims a year that people have to then go fight with insurance companies to get coverage for something that their physician, who examined them, said they needed. That's, the LA Times made it clear when they stated insurance companies are playing the odds. They're counting on people not having the stamina to challenge every denied claim, even when there's a valid medical reason for a drug or treatment being covered. And that is so true. Collective bargaining over benefits has become a massive transfer of our wealth as workers to insurance companies and pharma. It's become a powerful weapon that's being used against workers in the class warfare that we are engaged in. Workers don't love their employers having control over their health care. And newsflash, even employers aren't all that crazy about it. Most businesses would much rather know each year exactly what their health care costs will be without the uncertainty of annually having to negotiate premium costs, being forced to choose higher costs for themselves, or shifting those costs to employees through those high deductibles and co-pays, while restricting provider networks, causing employee stress because they may no longer be able to see the doctor that they're seeing for continuity of care. And under Medicare for All, unlike private insurers, you can always keep the same doctors in hospitals. So Medicare for All recognizes health as a basic human need, providing not only universal coverage, but also proven cost containment. Representative Jayapal's bill contains 4 essential cost containment elements. Next slide. First, it bypasses the insurance industry. What do we need them for? In healthcare. I mean, they're just superfluous. That's all I can say. The federal government will pay providers directly. This is about streamlining a payment system. This is not about socialized medicine. This is about publicly financed, privately delivered health care. It will not funnel dollars through 1,500 different insurance companies so they can scrape 20% off the top before passing the rest on to providers and hospitals. That's why we call Medicare for All a single payer. There's only one payer for our health care. Second, America's 5,500 hospitals will each get their own budget. That will cut hospital administrative costs in half. I was recently in Canada, walking around with union nurses, learning from them about the Canadian health system, the pros and the cons, because there's no perfect health system on earth, my friends, not a one. But I'll tell you, they sure wouldn't come down here for ours, no matter what you're hearing about those 2 people every year that cross the border to come down here for health care. And there's no statistics that prove that, and they do actually count those statistics up there, I want you to know. And as we were walking around a hospital, I said, well, so where's the billing department? And this nurse looked at me and she's like, you see Susie over there? Like, yeah. She doesn't like it when you Americans come up here and something happens to you, you just got to figure out how to do an invoice. Because you don't do billing like that. You just get a global budget for a hospital. And guess what? Here's the other talking point you're hearing these days. If we go to Medicare for all the rural hospitals are going to have to shut their doors. Anybody from rural Minnesota in here? In the room? All right. And what's happening right now in rural Minnesota with healthcare and hospitals? Ding, ding, ding. Guess what won't need to happen under Medicare for All. If you have global budgets, and we are doing this out of a one-payer system, the global budget looks at the needs of the community, not the bottom line profit of Mayo or Sanford or Essentia, and whether or not they think they need to make money in that community. Or they can't make money in that community, so they close the hospital down, rebuild another one towards the metro area because it's higher density. You build a hospital, you got to fill it, right? They will come and they will figure out how to do that. This is the way we save health care in rural Minnesota. is we make sure that we have hospitals based on the needs of the community. Third, doctors will be paid on a uniform fee schedule. That uniform schedule plus payment from just one payer will cut physician overhead in half. A lot of people say, well, we only reimburse at Medicare rates. Doctors are going to quit, they're going to leave the country, they're going to run away. I was just serving with a doctor the other night down in Mankato on a panel with Senator Marty, and he's a primary care doc, and he said, I did the math. And if I didn't have to pay all this administrative costs and just got reimbursed the current Medicare rate, which is not what we're talking about, by the way, we know that has to be raised, okay? And it can be if we get rid of all the administrative waste. He said, I actually come out okay, because I don't have to hire registered nurses to never touch a patient, but only be on a computer to input codes to make sure I get paid. He said, I'd rather have that registered nurse out in the community with me, helping people make sure they're able to test for their diabetes, right? That they've got everything they need to take care of their health. And finally, Medicare for All sets limits on what drug companies can charge. So to recap, Medicare for All does not cut costs by slashing provider and hospital income. It does so by slashing overhead and reducing drug prices. 1/3 of the $3.5 trillion we spend annually on healthcare is eaten up by administrative costs. 1/3 of $3.5 trillion? That's a heck of a lot of cash. Medicare for All will cut that in half, saving around $400 to $500 billion a year. Let's take that money and put it into healthcare. That's where it's meant to go in the first place. And pay the people who are providing the healthcare the money they deserve and the wages they deserve, instead of, oh, I don't know, Stephen Hemsley, who owns, United Health Group, made $66 million. Who'd he heal for $66 million? Yeah, right, just got money for his shareholders again. So you might be asking, so how do we pay for this? Well, it's actually pretty simple. We just remove all that, the unnecessary middlemen in the system who do not heal anybody, but add complexity to the system and bureaucracy and thereby cost. With no insurance companies, pharmacy benefit managers, and third-party administrators in the mix, there will be no administrative overhead, marketing costs, or CEO and shareholder profit. The pharmaceuticals spend 3 times more of their money on advertising to us than they do in researching and developing new drugs. Most of that work is done already by our tax dollars in public universities and through the National Institute of Health. They buy that then from them, and then they jack the prices up because guess what? They got to trade on Wall Street, and they have to make a profit for their shareholders. The single-payer system will allow for negotiation of provider rates and procedures and for negotiation of drug prices. Our state and country are already spending billions of dollars on health care. This will redirect those dollars and do it in a way that provides care for everyone with a better standard of care. It's important also, I want to mention, to beware of the Medicare for All lookalikes, I call them. Medicare for some is a hollow proposition regardless of how it's structured. This is the public option debate we're now having, right? Diane Archer, a senior advisor at Social Security Works, recently wrote an article about Medicare for some, and in it, she very clearly spells out the problem with these proposals. She says, quote, nonetheless, a number of thoughtful commentators and well-intentioned politicians are telling us that Medicare for All is not a practical approach to health care reform. These self-described pragmatists would offer Medicare as an additional option alongside commercial insurance, proposing a Medicare buy-in or Medicare for some. By any measure, Medicare for some would deliver very little for the American people. At best, it would capture a fraction of the health care savings created under Medicare for All. It would not address the unaffordable premiums, deductibles, and co-insurance that keep millions of Americans from getting needed health care, and it would leave tens of millions of Americans uninsured and underinsured. So too, Medicare for some does not address the most basic questions about our healthcare system. Why do we trust health insurers to determine the doctors and hospitals we can see? Why should a knee replacement cost anywhere between $16,000 and $61,000? Why should Americans pay twice as much for prescription drugs as our peers in Europe and Japan? And why should our health coverage depend on where we work? Let's get real. Commercial insurance is the biggest threat to healthcare choices and our freedom to receive the healthcare that we need. No one loves Aetna, Anthem, or any other insurance company. What we love and what we need is the freedom to get care from the doctors we want to see at a price we can afford. Medicare for All guarantees all Americans access to health care with freedom to see the doctors we want throughout our lives, wherever we live, wherever we work, and whenever we are out of work. That's about as pragmatic as it gets. Amen. We don't fix broken bones incrementally, and we can't fix this healthcare system incrementally. Princeton University professor of political economics Huey Reinhardt stated, if healthcare costs in the United States were lower, most people would probably agree that ill, low-income citizens should receive the needed healthcare that is available to better off individuals. The problem is that our healthcare system is in danger of pricing kindness out of our souls. Well, your nurses are working hard to make sure we don't price kindness out of our souls. So join us, please, along with farmers, people of faith, the Minnesota AFL-CIO, the National AFL-CIO, immigrants, the disability rights community, and yes, other senior citizen organizations who want to not only save Medicare, but improve it in the righteous fight to restore our humanity by putting patients above profits and enacting the Medicare for All Act. And let's finally get the profit motive out of providing health care and instead guarantee a single standard of high quality care for all. Last slide, because you can't cross a chasm in small steps. Thank you, brothers and sisters. See safe well.